Solid red rashes, most of the time people go to the emergency rooms and they're diagnosed with a cellulitis or a spider bite. So if you see one of these solid red rashes, know that this also could be a possible manifestation of Lyme. So disseminated Lyme, as I talked about, if you get an EM rash, any central nervous symptoms, neck stiffness, headaches, light and sound sensitivity, please make sure you speak to your doctor about needing longer courses. And remember that these Lyme organisms, Borrelia, they have cell wall forms. They have cystic forms. They go inside the cells. They have biofilms. When you want to treat this organism, you need to treat all of the different forms, and doxycycline alone will not do that. Now, if you have an EM rash with day sweats, night sweats, fevers, chills, flushing, air hunger where you can't catch your breath, you've been ruled out for asthma, and a cough you can't explain, that could be babesiosis. And I'll show you in a second why using questionnaires for this is going to be so important. Chronic Lyme is truly the great imitator, and one take-home message you must have is that if you or a loved one or someone you know has a pain syndrome that is resistant to standard treatment, whether it be chronic fatigue, fibro, some autoimmune disease, neurological symptoms such as migraine headaches, as Sandy talked about, or neuropathy. We see so many patients that have resistant neuropathy that are due to Lyme and Bartonella and mycoplasma species driving inflammation. But even from the GI-GU standpoint, you can see it with inflammatory bowel, with irritable bowel, with interstitial cystitis, where Lyme and Bartonella is playing a role. There can be pain syndromes in GYN like dyspareunia, painful sex, and neuralgia. Cardiac chest pain, which can be from costochondritis. Now, Lyme can cause cardiac symptoms. It can affect the heart, and thank God, most of the time it's not fatal. But it can be. And next month in Dutchess County, New York, for those of you who want to come and see this, on June 8th in the Bardavon Theater, the first theater production for Lyme disease is going to be presented based on a true story of a young man in Poughkeepsie who died from Lyme disease. He went down to Rhode Island to learn about ticks and environmental medicine. And he came back and died 3 to 4 weeks later. And his ELISA test was negative. They found Lyme throughout his body. He had a Lyme carditis. There's going to be a theater production based on Mary Stuart Masterson from Fried Green Tomatoes, and Benny and June and her husband Jeremy Davidson have produced this show. They're going to be there at the Bardavon. There's going to be a reading of the show. I will be on the stage at the Bardavon afterwards doing a question and answer. They've opened up the Bardavon. There's over 1,000 seats, $6 to come and attend, meet the directors, meet the family, and learn about Lyme disease if you have a chance to do it. Psychiatric symptoms. Lyme mimics every psychiatric manifestation known to mankind. Brian Fallon has done some amazing work on this. If you looked at the ICD-9 or 10 manuals and you looked at OCD and psychosis and depression, anxiety, panic disorders, oppositional defiant disorder, every one of these disorders can be caused by Lyme disease and made worse by co-infections like Bartonella. So it's very important for mental health professionals to screen patients for this, and I'll show you the questionnaire that we use, which we've now validated through the SUNY Newport system. I'll show you the statistical validation that we've done on it. You have to make sure you check for endocrine problems with Lyme because men can come in with early andropause. I have men in their 20s with no testosterone. About 40% of my patients lack adrenal function. You will not get better from antibiotics until your hormones are fixed because these inflammatory molecules, tumor necrosis factor alpha, interleukin-1, IL-6, they affect the pituitary gland and they shut off hormone production in some people. And if you don't clear that problem with getting the hormones back in balance, people will not get better. And finally, there are painful eye syndromes that you can see with Lyme and also with Bartonella. There are some recent studies showing that Bartonella is even showing up, standard Bartonella, in cataracts, about 18% of the cases. Breischwart just published on this. How, as a clinician, would you suspect that someone has Lyme disease, or what I call Lyme MSIDS, with these 16 overlapping factors? This is really key. It's very easy. Do your symptoms come and go with good and bad days? Does the pain migrate? Do you have joint pain that one day is in an elbow and 2 days later it's in your shoulder and 3 days later it's in your knee? Same thing for the muscle pain, which migrates around the body. And same thing with the nerve pain. The tingling, numbness, burning, stabbing sensations moves, it comes and goes and moves. So unless you were someone that had carpal tunnel where it was in one place, where you had diabetic neuropathy, nerve pain doesn't move around the body. The symptoms are influenced by hormonal cycles in women. They'll tell you right before, during, after their menstrual cycle. Their symptoms are much worse. Classic for Lyme. If you took an antibiotic and you didn't know you had Lyme, for example, an upper respiratory infection, you might say, my chronic fatigue symptoms are better. My fibro symptoms are better. You stop it, it comes back. Or you may get worse. You may have a Herxheimer reaction, where again, these inflammatory molecules, these cytokines are released. Your pain can be resistant to standard treatment modalities. And Lyme is a multisystemic disorder. So if someone comes into my office, I have them fill out a questionnaire to see if they have a multisystemic problem. And the screening questionnaire, it's in my book, but it's also on my website, and doctors and patients can download it. The website is cangetbetter.com. I used this initially from a questionnaire that Dr. Morscano had done years ago, but what I did differently is I scored the questionnaire and I weighted it. I weighted the symptoms, the 38 questions, as far as how often do you have these symptoms, but also answer yes in section 2 whether you've had a tick bite, or a rash, or family members with Lyme. Do you have migratory muscle pain or migratory joint pain? We weighted this. We then used the CDC Healthy Questions from one of their questionnaires about the number of days per month you have good physical health or mental health. And finally, if you had a constellation of fatigue, memory problems, joint pain, tingling numbness, or sleep, which turns out that these were the same constellation of symptoms. In Shattuck's work in the New England Journal of Medicine in the late 90s, the same constellation showed up in this questionnaire when I was doing it. So what we did is we went to SUNY New Paltz, and we had Mariella Cetera take the questionnaire. She gave it out to 330 patients from different medical practices and 161 people recruited through email and social media who did this online. They examined this questionnaire for factor structure, validity, reliability. And what it revealed is there were 5 factors consistent with Lyme. You had fatigue, flu-like symptoms, joint stiffness, tingling, neuropathy, and concentration problems. And what they showed is that this Horowitz Lyme questionnaire demonstrated convergent, divergent construct validity as well as predictive validity. What this means is that if you score 46 or higher on this questionnaire, you are 2 standard deviations above the mean, there's a high likelihood you have Lyme. The reason this is important is because the blood tests are unreliable. So if you're a mental health professional or a psychiatrist, and you have a patient with depression and anxiety, you just have to hand it out in the waiting room, see if they have a multisystemic disorder, and send out the test. If you're an obstetrician gynecologist and your patient is pregnant or wants to get pregnant, because this is dangerous for the fetus and for the mother, you give it out to the patients while they're waiting. If they score high, this is an easy first screening test, just without having to spend any money for testing to be able to give you at least a first impression on Lyme. Even the CDC and the health departments have told you it's a clinical diagnosis. Even Gary Wormser, in a recent study that was just published on Healthline, and did an interview for Healthline several days ago, Dr. Wormser actually admitted also it is a clinical diagnosis and that the tests are not 100% reliable. But clearly we do have a problem with blood tests, because if you have 100 different strains of Borrelia in the United States and 300 strains worldwide, and Quest and LabCorp and BioReference used the B31 strain, one strain to pick up all these different strains of Lyme, you're just never going to get it. So what IGeneX does is they use the 297, they add it, and we do find that the bands on the Western blot are usually much more visible, and you're looking for the 23, the outer surface protein C, the 31, the outer surface protein A, the 34, the outer surface protein B, the 39, and the 8393. If you have any one of these Lyme-specific bands, and you are a patient who has a multisystemic disorder and you've been ruled out for other diseases, then you have a very high likelihood of having Lyme disease, because these are Borrelia-specific bands. So I do not use 2-tier testing by the CDC. I do find, however, that occasionally the C6 Lyme ELISA peptide is more reliable. It's certainly better on spinal taps, but we do find that we can pick up more positive tests, and I spoke to Ben Beard from the CDC a few months ago about this, and he said it's because it's picking up some of these other strains of Lyme. So we have actually found a lot more C6 ELISAs that are positive than standard ELISAs when we test in our office. PCRs, lymphocyte transformation test culture, you can certainly use them, but of course you have to do multiple tests for PCRs to be able to pick it up. The thing about Babesia testing that's so important is that if you don't do a panel approach, there's a lot of Wall1 Duncani Babesia, and doctors miss it because they just check for Babesia microti. We did studies from Florida all the way up to Maine and found that there was Babesia Wall1 Duncani on the entire Northeast. And I told this to Ben Beard, and also when I was at Harvard to Peter Krause, that LabCorp and Quest are finding Babesia Wall1 Duncani in my patients in a fairly high percentage of the cases. So you have to make sure when you're doing titers, do it for Babesia microti, but also for Duncani. You may need a FISH test from IGeneX, the fluorescent in situ hybridization, which is an RNA probe. When we were in China years ago and we presented this to the Chinese CDC and their Science Foundation, we showed them that they were looking at this 18S ribosomal RNA and they weren't sure if it was Babesia. The FISH test was positive. They were very impressed, and this test is approved in New York State by the Department of Health. And occasionally PCRs can also be useful. But as Pat talked about, you've got to take out the net and basically throw it out looking for all these tick-borne infections. I find a high number of my patients test positive for Rocky Mountain spotted fever, for Coxiella burnetii, Q fever. We find a fair number of Bartonella cases. But interestingly enough, even brucellosis cases, we're starting to see a rise in brucella cases, and I've seen certainly some tularemia cases also through my office. So you've got to check for all the associated tick-borne infections, even if you don't think they may be there, you're going to be surprised. But the most important thing is to screen for all 16 points on the MSIDS map. We've got these two standards of care. You know about them, the IDSA and ILITES. IDSA says that the tests are reliable, and patients with persistent Lyme symptoms, we don't know, maybe it's autoimmune, they have post-treatment Lyme. And ILITES guidelines, basically the tests are unreliable and multiple factors on the MSIDS map will account for these persistent symptoms. Interestingly enough, even going back to 1996, published in Infection, Dr. Danta had published that many doctors in the US don't follow IDSA guidelines. They treat for seronegative disease for extended periods of time, and 57% of responders treated 3 months or more. Now, this goes back to 1996. And when we look at this article that was published in the Archives of Internal Medicine back in 2011, when they analyzed the IDSA guidelines, they found that half of the recommendations basically were based on author opinion, called level 3 evidence. And that is not what happened with the recent ILITES guidelines, that's in Dr. Cameron. The CDC data that came out in 2013 also confirmed that over half the doctors in the United States do not treat using IDSA guideline. It's basically because they just don't work in clinical practice, right? Our job as doctors is to make patients better. It's not to follow guidelines blindly, and the IDSA guidelines do not work in clinical practice. So we need to change this, because when I go to Europe and I lecture in Europe, they have the same problem because they've adopted what's called the UCAL criteria, which is exactly the same IDSA criteria here. But if you look at what the scientific peer-reviewed literature says, it says, according to the studies you can see below by Mangaroni and Ang, you're going to miss roughly half the people with Lyme disease using these tests. So the two-tiered protocol is just not reliable. We all know that. The C6 limelized peptide, I'm suggesting you do look at it a little bit more. I've certainly seen more success using it. But you've got to look at those Borrelia-specific bands, because that tells you you've been exposed. And also, 10 to 20% of the Borrelia are not Borrelia burgdorferi, but are now Borrelia miyamotoi. So you do not expect the two-tiered test show up positive. So remember, when I showed you all these expanding Borrelia species, you would not expect the standard two-tiered testing to pick it up. So remember, there is borreliosis. You can get Lyme-like syndromes, and your Lyme may be a combination of multiple species of Borrelia, and that's probably the case at this point in time. We see the same problems with trying to diagnose Babesia. There's over 100 strains of Babesia pyroplasmosis in the world. We only check generally for WAL1 and Microti, and there are over 30 Bartonella species that are present, and they're discovering new ones all the time. So you can't just look for Bartonella, henselae, and Quintana to be able to find the species. I'm not going to spend a lot of time, but when you've heard from some doctors, and the ideas say that there is no evidence that Lyme persists in the body, here's 6 scientific references, and here's another 5 references, and here's another 6 references, and I have more slides, I just took them off for time reasons, the last one being the one by Monica Embers on rhesus macaque monkeys and Straub, which is a wonderful work in dogs. And then we have the xenodiagnostic studies, where Hotzig took mice and they gave them Lyme and gave them some of the standard antibiotics you would take. And then they put ticks that had no organisms on the mice to see if they could find any evidence of Borrelia. And in fact, they did. They confirmed that they could find RNA transcription of genes months later. So they couldn't culture the Borrelia, but they basically found DNA and transcription, meaning it was still alive. But what about humans? Adriana Marquez did the first in-human study in post-treatment Lyme disease and found exactly the same thing, that patients with post-treatment Lyme, one of those patients was PCR positive, several were indeterminate. I'm not sure how they ended up with bad testing through the NIH, but they said 2 of those were indeterminate, but 1 was positive. Lyme persists. It can't be the only exception to the rule where a positive PCR for hepatitis B means you have chronic hepatitis, or a positive PCR for hepatitis C means you have chronic hep C. This cannot be the only exception to rule in medicine, that a positive PCR in DNA means you don't have chronic Lyme disease. That's political, that is not medical science. So we have treatment failures because of persistent, because these organisms will sequester in antibiotically privileged sites. Even Dr. Klempner, who did the first double-blind placebo-controlled study, also did a study showing that fibroblasts in the skin will protect against rocephin, being able to kill it off. It can get into the eye, and right in the eye, I don't know if you saw this article on Ebola virus, but one of the people who was, some of you have actually seen this, that this man lived through Ebola virus. They could not find evidence in his blood, but it was in his eye, even after treatment, that the virus was persisting in the body. Persistent infections, who knew? Ligamentous tissue, joints, CNS. Dr. Liebner had a very important case years ago, Vicki Logan, a nurse. She was treated for years of antibiotics. The CDC and NIH were following this particular study. The insurance companies eventually denied her getting further treatment. She died. Dr. Liebner has some footage of this, of her speaking to people. And they went in and they did brain biopsies and spinal taps, and they found that the organism was still there after years of treatment with IV antibiotics. This was again followed by the CDC and NIH. And then finally there were biofilms, which some excellent work has been done by Eva Shoppe and Alan McDonald. So again, if you're trying to get antibiotics to kill these bugs, they're covered by biofilms. And biofilms infections, by the way, are not new in medicine. Salmonella, for example, which is known to persist in the body and go into the endothelial cells and persist in some cases. Also, biofilms is one of the reasons it persists. The ENT doctors will tell you part of the reason people have problems with chronic sinus infections is biofilms. We just started talking about it in Lyme in the last couple of years. And then we have treatment failures because under stressful conditions, when heat shock proteins are formed, these organisms can also form these L forms, S forms, cell wall deficient forms, cystic forms. So this is one by Priyak Merzik, and he has shown that he can transform these cystic forms into mobile spirochetes. They've also found these in patients with multiple sclerosis, by the way. So again, in the scientific literature, we can show persistence with cystic forms. Dr. McDonald has found it in Alzheimer's patients in the NIH data bank, where 7 out of 10 patients show the DNA evidence of Lyme when they've had Alzheimer's. Now, this doesn't mean that Lyme causes Alzheimer's, but as I'm about to show you, inflammation, if it comes from multiple sources, may be causing amyloid plaques. One example would be that in Mexico City, there was a scientific article published on children who died in car accidents at 13, 14 years old in Mexico City. They did brain biopsies and found amyloid plaques in the brain. Environmental toxins, Mexico City is one of the most polluted cities on the planet. Environmental pollutants that are getting into our bodies, lead, mercury, PCBs, dioxins, plastic pesticides, heavy metals, they cause free radical oxidative stress. They also can cause amyloid plaques. When we look at those double-blind placebo